You mentioned some of the treatment depends on the overall health of a person.
Yeah.
Were you talking about like a medical health thing, or how fit they were? Is there anything you can do at home, basically, that you know of?
Well, look, generally, you're right. It's sort of medical health by way of whether you've got other things going on, because those patients that have severe heart disease and heart pumping function problems, severe respiratory disease, such as emphysema, asthma, fibrosis of the lung, any of those things. Generally, kidney disease is not a limiting factor because of that's what we're treating in the first place, and we even do transplants on people that are on dialysis. And then any other factors. So in terms of if you have myeloma and are you fit enough as going to the gym or doing physio and exercise or anything, generally not, that's not going to change things much. But by way of you having usually these treatments prior to transplant are outpatient based, maintaining movement and exercise and maintaining a good diet are all important. I think it's important to point out too in terms of diet that even though this is an abnormal protein which is produced by immunoglobulins, reducing the protein content of your diet doesn't affect that at all. I guess it's just that our bodies are made up of millions of different proteins, and what we hear in the popular press or what we hear about dietary advice is different to when we're talking about an abnormal immune protein here. So, yeah, I guess does that answer your question?
Yeah, that's good, because that had occurred to me, they were cutting back the protein.
No, it's not going to make. It doesn't make any difference.
Can we just repeat the question also, just for the?
Oh, okay, sure. So the question was with regards fitness for transplant, whether that is talking about general fitness or we're talking about medical fitness of comorbidities, really is what we're talking about, or co-illnesses that people may have going into a transplant. Excellent. Okay, that's a very good question. So the question is, what's the significance of levels of plasma cells in a bone marrow, particularly if it's picked up incidentally looking for something else? So when we see, if we did a bone marrow on a stock standard normal person, which would be pretty odd because we don't really do them on normals generally, the plasma cells would be only about 1 to 2%, and they would be all normal ones, and they wouldn't be what we call lambda or kappa restricted, meaning that they're not all going the wrong way in production. People that have MGUS, or this monoclonal gammopathy of undetermined significance, will generally have plasma cell numbers less than 10%. So among them, they may have what we call clonal plasma cells, but the presence of those less than 10% will qualify them as being not myeloma yet, or this MGUS. Once you get more than 10%, then it's qualified as myeloma. And then you need to look at symptoms and that CRAB criteria to say, is this symptomatic myeloma? And usually people that have symptomatic myeloma will have plasma cells in excess of 20, 30%. Some people have packed out marrows of 80% plus, where it's really left with very little normal marrow to produce blood cells. So it varies greatly, but generally the diagnosis of myeloma requires more than 10% plasma cells. So the three main blood cancers are lymphoma, leukemia, and myeloma. Myeloma really sits out on its own because there's only one real type of it, with all these genetic changes and a few things which do change staging and so forth, but there's only really one type of it. They produce different proteins and a few things, but lymphoma, you've got about 60, 70 types, Hodgkin and non-Hodgkin. You've got leukemia, of which there's chronic and acute, and of which there's about a dozen to 2 dozen types, depending on where you split the line. So all of those I qualify as blood cancers, and I think is better understood as that. Whether you include MDS is questionable.
Supposedly transitioned into acute myeloid leukemia.
Yeah, well, that's certainly good question. So the question is just a 78-year-old gentleman who's had stem cells collected previously, and what's the length of time for storage of the stem cells, and are they going to be of any use at this stage? So how long ago did you have them collected?
2001.
So they collected in 2001, which is 12 years ago, and they had half of them used immediately or a few weeks afterwards? Yeah. So look, it's a good question. Generally, at the age of 78, we probably won't be going in to use them again, particularly with all these new agents available. The length of storage really is indeterminate. Generally, they don't really go that well after about 15 or 20 years, but the thing is that they have to be pulled out, or sample needs to be pulled out of storage and defrosted and see what their viability or how alive they are. If they are alive and they can be thawed and work all right, then we go and use them. But that would be if you're a suitable recipient to get them and to go through the process of having high dose therapy, which knocks your bone marrow so much to have them. So should you keep them? They're probably unlikely to be used. If you got them stored in the private sector and it's costing you money each year to keep them, which may be something to think about, I can't say for certain if your doctor may choose to use them or not in the future, but generally we would not, if we were still left with what we had 10, 15 years ago, then maybe someone would pull them out of the hat, but generally we've got lots more options for people that are 78 with relapsed myeloma. Well look, for autologous collection, then those are stored for the purpose only for yourself. Stem cells can be given from one person to another in a process of allogeneic transplant, but they're in highly selected cases, and usually stem cells are collected and given to another person fresh without being frozen, and that's how allogeneic transplants are usually done. And when they're given to someone else, it's a lot more complex procedure by way of having issues related to a thing called graft versus host disease, higher risks of infections and so forth. Could they be used for other than myeloma? Well, potentially if someone got a secondary cancer that we wanted to treat, like a lymphoma, again, potentially that would be probably the only situation where we would pull them out again. But the use of second transplants is still used in people that are young enough, and that sort of binds into the last question. If they've had a very long remission from their usually sort of 3 to 5 years or more, and we want to go back and do that again rather than moving on to another agent. But generally, unfortunately, those cells won't be used for the purposes to be given to someone. The PA and the ALLG do have a tissue bank where they store components of stem cells, particularly for people that are collected at the PA, to be used for research purposes, but not for any therapeutic use. They're for be used like in a petri dish on a lab bench, and that's about it. So unfortunately, they don't, while they're stored for the purposes of therapeutic use, they can't be used for research nor given to another person. It depends on how much is left. If they were to have third transplants, are pretty rare. You usually need to have 2 million per kilogram of CD34 cells left to be able to be useful. One bag usually doesn't contain that amount, but it depends on what was collected at the time, which I can't tell you. So generally, there would be limited use of it, but again, on a case-by-case basis, I can't say for sure whether they could be utilised, but they generally wouldn't be used for anything else other than to help restore the bone marrow after high-dose therapy. So the issue comes if you have already had melphalan and a transplant. Coming back to collect your stem cells becomes extraordinarily difficult. By way of our methods of giving a bit of chemotherapy and then using GCSF, it's virtually got a failure rate of probably 95% plus. But we do have a new expensive drug which is ongoing campaigning to have the government pay for. It's called Mozobil, or Plorexafor is its generic name, and that drug is able to be used for people that have failure to collect their stem cells. One or you or relatives may have been able to use that drug to collect the stem cells up front, but generally we won't go back to try to collect the stem cells using that. So it's because the melphalan is so toxic to those stem cells, and that coming back later in the future. That's why the general approach is to collect enough for 2 transplants, leave a bit in reserve. That bit in reserve may never get used. It may be superfluous, either get too old or now newer agents have come along. So whether our approach stays that same to have enough for 2 transplants is still to be determined, and whether we whether we ever come back to collecting stem cells with another drug on board is another question too, but generally Mosabil will probably not be used in the setting of saying, well, you've already had a transplant, use your cells, we want to come and do it again. It wouldn't be approved under that setting. Well, look, in terms of treatment, when you're on treatment for myeloma, it's usually done every cycle at least, so whether that's every 3, 4, 5, 6 weeks, depending on what treatment regimen you're on.
No treatment.
And if it's no treatment, then it depends on the rate at which the protein's going. If you have MGUS, this pre-myeloma problem, and it's been very stable for months and years, then generally checking on it maybe every 3, 6 or even 12 months may be all that's needed. For people that have previous myeloma and their level and they've been on maintenance and then we're checking on it, generally we will look at them every 1 to 3 months at the very most. 3 months would be if for someone who's had previous myeloma.
Is that more important than taking it from the protein plasma from the bone marrow? Is that giving you
we use it as a surrogate marker, so the protein in the blood is a surrogate marker as to what's going on in the bone marrow. If we see it rising and suspect a relapse or that the disease is progressing, then going back to doing bone marrow is how we quantify what's happening there, as well as other restaging, which I didn't go into all that today, but skeletal surveys or doing x-rays, or now we've generally moved to doing whole body MRIs and collecting the urine for 24 hours, or Bence-Jones protein for over 24 hours. So those things usually are where the blood test is the regular test to mark it. If it goes up, then we may look to go and do the bone marrow again, but regular bone marrows generally aren't indicated or needed, unless in the very rare circumstance we have what we call non-secretory disease, where there's no protein being put out and you have to do bone marrows to go and have a look. The question was about the role of Iridia causing osteonecrosis of the jaw. So osteonecrosis essentially means bone death of the jaw, regular jaw, not know a second meaning for jaw. And so it's a process where the bone can die off because of giving these intravenous drugs, and applies both to Iridia, which is generic name's called pamidronate, or Zometa, which is generic name is zolindronate or zoledronic acid. And I thankfully have not seen any cases, but know of patients that have had it at the clinic at PA. It is important to maintain tooth health, and if things are going bad, to have a break off it, because we know if people have a tooth extraction whilst on it, bone fails to heal, and you get raw, exposed, painful bone that can just die off and can cause severe sort of melting away of the jawbone there, and especially with exposed bone with no gum over the top. So thankfully it's a relatively rare side effect, but we do see it still, and we try to maintain. People do have dental checks and have all needed extractions well before they go on to have Iridia or Zometa. So is it a thing that you worry about by way of being on treatment, or have you had a problem with it yourself? Can I answer that? No,
I've been on already, but
yeah,
I just wanted a second opinion.
Yeah, look, it's thankfully is rare, and we don't hold off on giving it, and only until we realise that people's teeth health are okay. But it's sometimes people may be limited for many months to have it until their teeth are all sorted out. But it certainly has made, Iridia and Zometa have made a big difference in terms of that crippling, bony, breaky disease which myeloma was for several decades, and obviously several centuries before that.